Chairman, ladies and gentlemen, I'm Po Ting Wu from National Cheng Kung University, Tainan, Taiwan. Today is my great honor to report our work here. So even now, our concepts for the fracture management become better, but I think the delay union or non-union is still a problem. According to the literature, the incidence is around 5%. And now, because of the advance in the biomaterial, so we know the BMPO, just like the PTH teriparatide, can facilitate the fracture healing. But the problem is, should we put in the initial fracture for the fresh fracture? So this is another question. And about the laser, I think this is not new, but in the past, now because advance in the technology, so now the laser intensity can be increased. According to the literature, the so-called HIL have some benefit in the musculoskeletal system problem, just like low back pain or spine disorder, or even the knee osteoarthritis. And what is a high intensity? That means you can provide a higher energy, so it can penetrate deeper and provide a wider area to facilitate the tissue regeneration. The basic concept is when our tissue receive the stimulation from laser, so you activation the mitochondria and provide the growth factor and provide the cell proliferation, something like that. And our previous work find the past Nd:YAG laser can enhance the nerve regeneration in the peripheral nerve injury rate model. So this is what we use the commercial machine. So this time we want to evaluate its effect on the fracture healing in a rat model. So this is our scheme for our whole work. Initially we use the control group. Another is a laser group. And then we have the 3 time point, 2 weeks, 4 weeks, and 6 weeks. In the 3 time point, we check the image, use the micro CT, and then the specimen to perform the biomechanical test, another half to do the histology evaluation, including the IHC, to evaluate the neovascularization, and about another is osteoblast recruitment. And because we believe the angiogenesis and the osteo recruitment, it should be happen very earlier. So at week 2, we check another Western blot from the tissue to check some biomolecular marker. So this is our laser protocol. For the laser group, we received 10 days. And this is for the image and for biomechanical. So this is just like what we use in the clinical. We use a micro CT, and we divide in the just so-called AP view and lateral view. And we use the ROS score. For each specimen, we divide in the 10 section. And that means the ROS score, the minimum is 1 point. So this means if you got the 40 points, this means no healing. But if maximum is 112 points, so we can evaluate the union score on the micro CT. And this is we use the thresholding software to evaluate the mature bone volume. So divided to total bone volume, we can get 1%. This is the bone maturation index. And then we perform the biomechanical test. One is a fractural model, another is a strain. And about the histology, we use some paper mentioned about the healing score. So evaluate if it becomes mature, finally it will become the bone. So we can clearly evaluate serially. And finally, we use the IHC to test the CD31, this means the neovascularization. Another is RUNX2, so representative the osteoblast, the activity. And this is our Western blot. We use the VEGF and CD31 to evaluate the angiogenesis. Again, the RUNX2 for the evaluation in the osteoblast recruitment. So this is our randomization protocol to avoid the equal distribution of our animal. And for the statistical analysis, we do the normality test first. If it's a pass, so we use the two-way ANOVA and then use the 30 test for post-hoc. If not pass the normality test, we will use the U-test for group comparison and use the Freeman test for a time effect. So this is our result. We can see after receiving the laser treatment, we can find the laser group at week 4 and week 6. The radiography laser group will have a better score. And the similar in the bone maturation, week 4 and week 6, laser group have a better mature bone, more mature bone. But in the mechanical property, only at week 4 show a significant between group difference. And the histology healing score reflect the biomechanical test result. Only at the week 4, we can find a significant between group difference. And IHC is to show the difference, the angiogenesis and the osteoblast recruitment in the early stage only in the week 2. And the Western blot to show the similar result to support our IHC result. So this is the first paper to use the ND-YAG laser to evaluate the bone healing in a fracture model. Previously, it only showed the bone defect model, still show the positive effect. But this study still have a lot of limitation. First one is because this is an animal, we need to translation to human. But the problem is how about the laser dosage and laser mode and exposure time? And most important is in rat, the femur is still very thin, but in human is thicker. So we still know unclear for the exact exposure dosage and how far the laser can penetrate. And for the mechanism, we found it's through the angiogenesis and the osteoblast recruitment, but the detailed mechanism is still unclear. The most important is in our daily practice, do we need the routine use? I don't think so, but so what is the indication still in doubt? So this means all we need the clinical study to evaluate. But according to our result, we still can conclude the past ND-YAG laser can accelerate the fracture healing. So this mechanism might be through the angiogenesis and osteogenesis. So this is our work. And luckily it's received by the bone joint research. Okay, this is my presentation. Thank you for your attention.